Good afternoon, and welcome to the virtual town hall for June 11th. Thank you for joining us today. In addition to the various updates from clinical operations and human resources, today we will also hear about an exciting new hospital initiative that allows patients to go home sooner. And we will hear from the Flexible First team regarding hybrid workplace models for the fall. If you have questions, please submit them to the chat box, and we will address them in our question and answer session. Also, you might want to defer your questions until toward the end of the meeting, as they may be answered by our presenters today. Before we get into our agenda, I would like to share a brief comment about one of our core values that I feel is particularly important right now. We've been through a trying, sometimes traumatic year, and we continue to hear about painful and unsettling news around the world. This is a time that I believe we need to remember the importance of our core value of inclusion. In a few weeks, we begin a new fiscal year. In different ways than during the heights of the pandemic, we will still face many challenges as we maintain our drive toward continuous improvement to advance health. We will still need the steadfast spirit of collaboration and inclusion, practiced with empathy and compassion for our patients and for each other. With our goal of continuous improvement, we will set high standards for ourselves that will challenge us. But if we commit to inclusion and the strong teamwork that sustained us throughout the pandemic, we will be able to meet those challenges and achieve our goals. I thank you again for your incredible endurance and perseverance this fiscal year. And I look forward to great collaborations and great achievements in the coming year. Now I'd like to transition to our COVID-19 operations update. As we have throughout the pandemic, our clinical operations are guided by a set of principles, including the patient and employee safety are paramount, continue to maintain access for COVID patients, as well as for patients with other conditions, maintain our commitment to citizens of the state, and mitigate the impact of the pandemic on our teams to the greatest extent possible. Can I have the next slide, please? There is good news. Hospitalizations in the state of Michigan for patients with COVID are now lower than they have been since the lowest point during the nadir in February and March of 2021. Next slide, please. The overall trends are reflected here at Michigan Medicine, where as of this morning, our adult inpatient census was 13 patients with COVID and 7 patients in our ICUs. Rates of positive testing have also been decreasing, both among symptomatic and asymptomatic patients. And I actually want to share a great email that I received from Dr. Lorraine Washer earlier today. As everyone knows, Lorraine has provided incredible leadership for Michigan Medicine throughout the pandemic. And Lorraine sent me the following message. Said, if you have an opportunity, you may wish to consider sharing this milestone. There are no new Michigan Medicine COVID-19 positive labs for June 11, 2021. It has been 357 days since we've had a day where there were no new COVID-19 positives reported. Thanks, Lorraine. This is really great news. Can I have the next slide, please? While there are many reasons for realistic optimism, it's also important that we remain aware of trends in the pandemic, both locally, regionally, nationally, and internationally. The emergence of new variants continues to contribute to some surges in infection, both in the United States and globally. The variants are now named with a convention using the Greek alphabet. And the Delta variant is particularly notable. This variant now accounts for 6% of SARS-CoV-2 isolates sequenced in the United States. There's data to suggest that this may be 60% more transmissible than the Alpha or B.1.1.7 variant. It may also be associated with increased risk for severe disease and hospitalization. Fortunately, current diagnostic tests detect this variant, and our vaccines appear to remain effective against this variant. The latter point again underscores the importance of increasing vaccination rates in the United States and across the world. Could I have the next slide, please? We continue to make progress with vaccination across the state of Michigan. We are currently at close to 60% for eligible individuals in the state of Michigan in terms of completed vaccinations. 71% of patients age 50 or older have initiated their vaccination series, and 42% of patients aged 12 to 49 have initiated vaccination. So good news, but opportunities for continued progress. Could I have the next slide, please? Here at Michigan Medicine, vaccination continues to be available with walk-in appointments with occupational health services, appointments at university health services, and patient vaccinations available at our Northville Health Center, Brighton Health Center, and North Campus Research Center. Many sites across the community can be identified at vaccinefinder.org. Can I have the next slide, please? I think it's important to also share some data regarding vaccination status and hospital admissions here at Michigan Medicine. This table summarizes the number of patients admitted to Michigan Medicine with a COVID diagnosis between March 9th and June 8th, and highlights the number of patients admitted with COVID who were fully vaccinated versus all COVID inpatient admissions. And the main message is that since March 9th, 2021, only 2.5%, or 12 out of 473 patients hospitalized for COVID were fully vaccinated. Among this group of 12 patients, 9 were immunocompromised or had pre-existing pulmonary conditions. Again, these data highlight the effectiveness of our vaccines and underscore the importance of our continued efforts to increase vaccinations for our patients, our team members, and our communities. Can I have the next slide, please? Now I'd like to transition to Dr. Grace Jank, Associate Chief Clinical Officer for Post-Acute Care, who will discuss an important care innovation that has emerged during and that we hope to preserve following the pandemic. Dr. Jank?
Thank you very much. You can advance to the next slide, please. So I think this is going to be the take-home message for my slide presentation today. And I want everybody on the line to be thinking about the future of acute care, and that currently we have acute care patients at multiple sites. Our Michigan Medicine providers take care of patients at the St. Joseph Mercy Chelsea campus. We also take care of patients at the St. Joseph Mercy Ann Arbor campus. And we have patients also here at University Hospital, the CVC, Mott, and the Women's Hospital. But our future is bright in that we have a new unit called the home unit, and that is hospital care at home. Next slide. So over the last year with COVID, we have built our capabilities in terms of how we can take care of patients at home. We have 250 of these patient monitoring at home kits, where we have sent home patients from the hospital with a cellular tablet, a Bluetooth blood pressure cuff, scale, O2 sat monitor. We're able to have nursing support 24/7, as well as video calls with providers, and we proactively manage patients. We've had excellent patient engagement and satisfaction with this, and we've been able to reduce readmissions and ED utilization for these patients who have this kit at home. We also have built our house call program. We have nurse practitioners and physicians who go out into the patient's home, and we address social determinants of health and their medical conditions. And again, we've had excellent patient satisfaction, and we've reduced readmissions and ED utilization. Our house call program also helps to bridge patients after a hospital stay to their primary care providers and their specialists, and we are able to provide virtual visits as well to help bridge that time period. And then lastly, at the bottom is our hospital care at home program. And you can see that's me in my PPE. And I'm taking care of a gentleman who had a perforated diverticula. He came into the ED with fevers, elevated white count, and abdominal pain. Our surgeons saw him in the ED and deemed him to be safe to go home with IV antibiotics and monitoring at home. He didn't need surgery. And this gentleman was able to get IV antibiotics at home. He was on his couch there with his puppy in his lap, and it was a great experience for him. And we're hoping to build this program, this hospital care at home, over the next several years. Each day we see those the emails from the emergency department saying that they're chock-a-block full, and we've got to figure out how to get patients home. And we know our clinical inpatient tower isn't going to be built for another several years. And so I want everybody on the line today to be thinking about, how can we utilize hospital care at home? Do I have a patient here who really isn't getting that much medical treatment, maybe some IV fluids, maybe some IV antibiotics, some IV diuresis, and all the time in between, really, they're just sitting there waiting. So could we potentially do this at home? And I think we really can. Next slide. So right now, patients come in on the left-hand side. They seek attention in the emergency department for acute issues. They're evaluated by an ED provider. And most of the time, these patients are hospitalized, going on the upper route. But what I'm here to show you is that there are patients who, with Blue Cross Blue Shield and Medicare Advantage plans, can actually go straight from the ED and go directly at home. And we have our ED providers looking for these patients, as well as care managers in the ED looking for these patients. We're hoping to expand this population to Medicare and Medicaid populations as well soon, once we have our conditions of participation met, and once we have a Epic inpatient virtual platform, we will expand that to our Medicare population. Up in the upper right-hand corner, though, we were able to do a completion of hospitalization at home pathway since November. We've enrolled over 225 patients, and we've taken these patients safely home with 3 liters of oxygen, and they get Michigan Visiting Nursing and house call virtual visits. And we've been able to show that these patients who are enrolled in this pathway have a 9% ED utilization, as opposed to 16% who weren't on this pathway. And the rehospitalization rate is also lower at 6.4% versus 14% who were not on the pathway. And so this is with COVID patients, but I think there are lots of other patients out there who can complete their hospitalization at home. And we're working with our heart failure patients, as well as our surgical colleagues for an ileostomy at home patients. And there are probably about 13 other target populations that we're going to be looking at to say, hey, can we do this safely in the comfort of the patient's home, and make this as patient-centric as possible. Next slide. So what does Michigan Medicine envision for the future of care at home? I think this is something that we are willing to look into. And as the need for tertiary and quaternary care grows, beds grow on the Hill, and payment shifts more towards value-based models over the next 5 years, we have the endorsement of UMMG executive leadership, the UMMG board, the cabinet, department chairs and chief to really look towards this future for care at home. We cannot stay status quo. There's just no way we can. And we really need to take our capabilities and grow them and target priority areas. We need to think about how can we use our capabilities in our risk-based contracts in the future and use this as part of population management? And are we are prepared to invest in resources in this over the next 5 years? And I think that is a yes. Next slide. We're building, like I said, in Epic, our virtual inpatient module. We're looking for target populations, and we're steadily building our team for hospital care at home. And so we can go to the next slide. I think the next slide really just summarizes, we want to be able to use our hospital wherever we can. So it doesn't have to be on the Hill. It doesn't have to be on our other campuses, but we can do this at home. And Mount Sinai in 2015 put out a New York Times Magazine ad that said, if we fill our beds, it means we've failed. And I think that's where Michigan Medicine is also looking to see if we can really do this patient-centric care in the most safe and effective environment that is the most cost-effective. And with that, I will turn this over to Matt Comstock and to Dee Hunt.
Thank you, Grace. And hi, Dee, good to see you. Happy June to all of you, and thank you for allowing us to present today. So some of you have heard about our efforts around creating a path forward and a new vision for the future of work at Michigan Medicine. And we're calling it the Flexible First Workforce and Workplace Initiative. Next slide. We've been working hard to craft this vision for the future, and our committee is very excited to share our progress today and to get your feedback both now and in the coming weeks and months. So Dee and I will give a brief update of the committee's work, and then we will close with some new resources now available, Dee, some next steps, and a few FAQs. Next slide. So the diversity of our work, our workforce, and our workplaces really makes Michigan Medicine, I think, a special place. You see on the left there, we employ over 29,000 faculty and staff, hundreds of different job titles. We have diverse units, roles, daily functions that meet our education, research, and clinical care needs. On the right there, you see we do our work in over 12 million square feet of space, and that was before the pandemic. On the Hill, at NCRC, around Ann Arbor, and across the state. We work in clinics and ORs, in vivarium, in classrooms, in our administrative office areas. And Dee, for the last 15 months, we've added our homes, our libraries, coffee shops, park benches to the list of places we do our work. Next slide. So our Flexible First Committee has assembled a framework for Michigan medicine to support our future workforce and workplace needs. So first there, we want to say we will provide support for every team member and every location across the spectrum of our functions. While many have been in person during the entire pandemic, some are just returning this summer, and some will remain remote until September. For those still remote, their return may be full-time on-site, it may be hybrid, it may be mobile, or it may be fully remote permanently. And Dee, you're going to highlight this here in a little bit. Second, we want to work together to determine optimal models that balance the needs of our organization with employee preferences. Because of the variability in our work at Michigan Medicine and in our workplaces, we know that individual decisions for employees and teams are best made at the department or unit level. There is no one size fits all. Finally, as more faculty and staff return to campus, we will continue to work on ways to identify opportunities to improve the overall work experience. I think we will iterate and adapt with time. We won't get it right away. We will learn from each other, and we will do what's best to serve the mission of Michigan Medicine. So Dee, I'll turn it over to you now to go over our Flexible First goals briefly, and then our workforce objectives.
Yes, thanks, Matt. Yes, the university put out some overall initiatives as we talk about returning to work. And they thought the key goals should be to address our teaching, research, and patient care missions, while also reducing the cost, space, and reducing environmental impact, and enhance our position as an employer of choice. In Michigan Medicine, we also started looking at goals to focus on. And we thought it was best for us to focus on building transparency and trust, supporting organizational change as we go through these remote changes. Consistency in our messages and guidance is going to be key. Supporting a culture of flexibility by all of us. And we also want to create opportunities for staff to reconnect. It's been 15 months since some of us have seen each other in person. And all while being effective stewards of our resources. These are all key goals that we want to make sure we focus on. Next slide. And as you look at this slide, I think the most effective staffing model for Michigan Medicine will center around a more flexible model where not all employees will return to campus 100% of the time. This plan will support employees and managers and account for the various models that you see below. We'll strive to be inclusive, as Matt has said, and account for the needs of all our employees, knowing that we all have different needs, provide some support and guidance to those who will and have already returned to the workplace, and then start to focus on how we come back to the workplace. The committees, subcommittees, and we have some great team members working with us on this, they have included the following, as you see below, some staffing models. The new employee resource matrix will provide guidance and support for different flexible staffing models. On-site, work primarily on-site for four or more days. The hybrid will work a split week, on-site and remotely. And mobile will work remotely for the majority of their work week. And then we'll have some folks who will continue to work 100% remotely. We also have put together a toolkit that you can see a little later as we end our presentation here at Town Hall. And you can go in there and find remote work resources for departments and units. The toolkit will provide helpful information for both staff and managers that includes some guidance and some best practices. As we continue to recruit others to our team to work with us, current and future job postings are updated to reflect the new structure, and all job postings will have the position type of remote or on-site, hybrid, or mobile listed in each one of our postings. Matt?
Thanks, Dee. Yeah, and we can hit the next slide. So that was the workforce. Now I'll talk a little bit about the workplace and some of our objectives you see here. So overall, we seek to provide, the tools and technology for a productive workplace regardless of location. So we're developing policies and guidelines around space assignments and utilization, which correspond to those flexible first employee models that Dee just reviewed. We are incorporating safety, security, and wellness into all of our workplace solutions. We seek to equip all of us with technologies to create new ways to foster dynamic real-time interactions. We want to ensure all employees have what they need when they need it to do their work with minimal hassle. We seek to create a workplace that is equitable for all workers, again, regardless of location. And finally, we'll look to utilize shared spaces in new and innovative ways whenever possible going forward. So Dee, I'll throw it back to you for next steps and how folks can engage.
Sounds good. So we know that returning to work on campus for faculty and staff will require us to be flexible. We need to be creative, and we need to collaboration by all our departments to ensure we enhance the ways the organization can accomplish our work. And we can do this. We remind our employees and our staff and leaders to be flexible and open to new perspectives as we go on this journey. Think about what we can do differently and move forward. We've outlined in our presentation that there's still work to be done by the subcommittees and various departments to finalize policies and resources, but there are some steps that can be taken now at a department level. And leaders, we're asking that you look at your operational and business needs and talk to your staff about their preferences and how they can work together to create an equitable and supportive work environment for all. Some departments have already begun this work and will be great resources as we roll this out to the entire organization. We'll share some lessons learned and some best practices for those experiences. And available now is on SharePoint, on our SharePoint site. That includes goals, deliverables, and objectives for Flexible First, as well as updates on the work of the workforce, of the workplace guiding principles, and workforce subgroups. So the site also contains a list of frequently asked questions that will be continuously updated, and as well as a tool that allows employees to ask questions, make suggestions, and offer feedback that can guide the Flexible First activities. And I think someone asked that question a while, how can we give input? This is how you can give input. The site soon will be updated with toolkits for managers and employees, and also will be a hub for news related to workforce and workplace planning. Matt, I think we can try to answer a few questions.
Yeah,
now.
I think that tees us up nicely, Dee. So if we hit the next slide, we put up a few FAQs here, and maybe Dee, I'll toss you the first one on what is the timing for rolling out those new employee models that you mentioned, and will employees still be working remotely until September 13th?
Well, we mentioned a couple of months ago that our new return to work date was September 13th. However, leadership is encouraging our managers to begin the process of addressing those business needs that I mentioned a little earlier, and having conversations with the staff to gather feedback and discuss their preferences that will help in planning the remote return to work strategies for them.
Thanks, Dee. And how about the second one there? Will we be issuing new remote work guidelines?
All employees continue to work remotely will need to have a completed signed agreement with their supervisor approving their current work remote arrangement. Those arrangements that we just talked about. Human Resources is revising the policy, the remote work agreement, and it will be available for managers and employees once we complete that review. Hey, Matt, so let's look at number 3.
Yeah. Well, go ahead. Sorry.
Would those who work remotely be given laptops and other work-related equipment or a stipend for office supplies, furniture, or internet costs?
Yeah, thanks, Dee. And we're getting this question a lot. And I'll first mention that HITS has a really excellent tech guide for working remotely. And that guide will continue to be updated. And I encourage you to work within your units to get the tools you need to get your job done. And so we want to be completely supportive. On the stipend question, Dee, we're still working with campus leadership on a university-wide view. And we'll hopefully have more to come on that question soon.
Okay. Can departments modify their plans after implementation if they recognize the model they selected isn't working for their business needs?
Yeah, absolutely, Dee. And I think that's right in our word of our initiative, which is flexibility. And we'll encourage departments to remain flexible, to recognize that the work they do today could change in a few months or even halfway through the year. And there'll be opportunity to modify those plans and make adjustments as we go forward.
So Matt, here's one last question. How is the research and education wrap up being incorporated into this work, since these areas are returning to campus sooner than September 13th?
Yeah, thanks, Dee. That's a great question. As many of you may have heard, our research teams, well, they've been working on site throughout the pandemic, some of them, and some are just returning this summer with greater frequency. Steve Kunkel announced right before Memorial Day that research faculty and staff can use offices and conference rooms again while following university guidelines. So I know Steve will have more updates coming soon throughout the summer. On the education front, our teams are preparing for a fall semester soon, sooner than we think, and ramping up activities in our MD programs, our PhD programs, our master's offerings, and we're all following guidance from the provost's office and other campus entities. So I will encourage both research and education teams to still review these guidelines and to work with your leadership to make the best decisions for their areas.
Great. Thanks, Matt. Appreciate your partnership.
Yep. Thanks, Dee.
All right, I will go on and give a quick HR update on some key things that we want to share. Next slide, please. Just to share that with you, that as we're nearing the end of this fiscal year, which means leaders and non-bargaining force staff should be wrapping up their FY21 valuation process. As a reminder, the deadline for submitting valuations to the HR Solutions Center is July 30th and should be submitted electronically. Over the next few weeks, if you haven't already done so, you should start to focus on the following things: getting feedback from peers and customers through our 360 review, attending a virtual informational session to ask questions and learn how to complete the forms. The next general session is available on June 24th, and a leadership session is available on June 17th, and registration is available on Headlines. Schedule your last FY21 touch base with your leader to review your goals and complete the remaining part of your evaluation form. And then make sure you're thinking about job-specific goals that you might want to use in FY22. Also, the latest version of the FY21 evaluation and additional resources can be found on the Michigan Medicine website, HR website. Next slide. We can't say thank you enough. We really can't. This last update is just to give recognition and thanks to all of you for what you've done over the last 15 months. And at the end of the month, you'll see a recognition bonus in your paycheck. We know you face extreme challenges and duress throughout the pandemic. We thank you deeply for all your efforts during this very challenging year. We have surpassed the clinical activities and volumes we are originally forecasted, which is excellent and reflects our ability to manage COVID-19 patients and non-COVID-19 patients despite the multiple surges. It is with great gratitude that we offer a recognition bonus of $1,500 to all Michigan Medicine faculty, staff, and house officers, including bargain for employees, to express our tremendous appreciation for your commitment to Michigan Medicine and to our patients. While the bonus is no way offset the many sacrifices that you've made over the past year, it is one small way we can acknowledge the spirit of people that continue to show up to work every day with their best self, even in the most trying circumstances. The bonus, again, will be reflected in the June 30th paycheck for our monthly employees and July 2nd for our bi-weekly pay employees. Employees must have been actively employed as of April the 1st and active on July 11th, that's today, to receive this bonus. Again, we extend our sincere gratitude to you for all that you've done, the dedication that you've done, the sacrifices you've made, the hands you've held, the tears you've wiped away, the support you've given to your employees. We can't thank you enough. And as a team member of yours, I truly thank you for all that you've done. So with this recognition bonus, we hope that you realize that this is our recognition and appreciation for all the work that you've done. Now I'll turn the next presentation over to Rose Glenn, our Chief Marketing and Communication Officer. Rose?
Thanks so much, Dee. It's a pleasure to be here today, and it was great to be able to come right after Dee's recap of the wonderful appreciation. I'm here to talk briefly about our brand architecture realignment. So if we could go to the first slide. When we held focus groups in the fall of 2019 around our brand campaign for the future, we asked all kinds of questions around what our differentiators are, why you came to work at Michigan Medicine, and I've had a great discussion with dozens of faculty, staff, and learners. During that time, we also learned there was a lot of confusion on the architecture. And we knew that if we were going to roll out a new brand campaign, we needed to make sure the architecture was clear, crisp, and understood, both internally and externally. So we put these guiding principles together, and we wanted to make sure they were really embraced. And so the guiding principles were we were going to represent our tripartite mission very clearly with both internal and external stakeholders, and leverage our storied history and the university's global brand. Now, this was the next one's a tough one, but we wanted to simplify the architecture and the hierarchy of the brand to make it easily understood. And of course, it's always important to make sure it's consistent across all of the uses of our brand and logos. Next slide. Just a couple of other things around the Michigan Medicine name. We are continuing to use that Michigan Medicine brand. It was introduced 5 years ago, but what we're doing now is providing clarity for what it is. Michigan Medicine is the master brand or parent company of both the health system and the medical school. Michigan Medicine isn't the health system by itself or the medical school. It is the organization that encompasses both. So it really represents our tripartite mission. So we needed to make sure that that was clear in how we portrayed our brand. The other things about Michigan Medicine is that it is short, it's easy to say, it's already in use and required no changes. Next. So today, it was a little confusing, or I should say how we had been using Michigan Medicine. We were using it as that parent company, but then we were also using it to describe the health system. And then when you looked at the medical school logo, there was no Michigan Medicine. So when you looked at the brand architecture, there wasn't alignment, and there wasn't a clear hierarchy on how we should use our brand and our logos. So we did a little work, and the next slide shows what we recently introduced to the organization. So Michigan Medicine, again, still at the top, still our master brand. University of Michigan Health System never really went away, but it wasn't being consistently used anymore. So our research showed that the word system was superfluous. It was not needed. It added length to our name, and people don't even think the word system is a very friendly word. So we dropped system, and it's going to be University of Michigan Health. On the other side, it will still be University of Michigan Medical School, but you can see the balance between both logos. Michigan Medicine is underneath each of those names, endorsing it. And it works really well because it provides clarity to the roles of each of our three main brands: Michigan Medicine, University of Michigan Health, and University of Michigan Medical School. And it provides for consistent use of Michigan Medicine across all of our logos. Plus, it reintroduces the words University of Michigan Health with an abbreviated name that provides our clinical branch with clear identity and distinction. And if you flip to that might have been my last slide. Yes, I know that in the question queue, there are a couple questions on brand, but I will turn it over to Keith and allow him to facilitate this part of the discussion. Thank you very much.
Thank you, Rose. And thanks everyone for the many questions in the Q&A. I'll just say at the outset a quick apology. Apparently my next door neighbor doesn't know that this is time for the town hall, and he's chosen this time to mow his lawn. So I apologize for the background noise. Let's see here. Let's actually, Rose, why don't we go ahead and start with a couple of questions related to the branding. 1 second, let me.
Yep.
Thank you, Rose. 1 second here. A couple of questions. One, where does Metro Health branding fit into this branding scheme? I know you've thought about that, but you didn't share that level of detail here. But if you could,
Sure.
that'd be great.
I've been working really closely with the leadership from Metro Health, and they are going to fit really nicely into this new brand architecture. They are going to introduce this new element and change in their organization at the end of June or early July. So I can't preview it yet, but it is going to align well.
Super. Thanks for that. And then Rose, got a pretty pointed question, around the timing and expense associated with this work. One person writes, as we continue the ERP and many people have been frozen out of a raise or equity views or just overall low pay, why was it thought necessary to bring a branding architect to change our name from Michigan Medicine back to University of Michigan, though I think your presentation clarifies that Michigan Medicine is not going away. But then also they go on to note that many of their staff, find the expenditure at this time insensitive. So I wonder if you could speak to that.
Yeah, I'm glad to address that, Keith. And as you know, that question came in before my presentation. So I hope it clarified that Michigan Medicine is not going away. We are clarifying its use, and we're clarifying a University of Michigan Health as the arm that represents our health system. And we're making sure Michigan Medicine is clearly underneath both the health system logo and the medical school logo. Regarding expense, we actually delayed the architecture work for a while. And then when we did do it, it was tweaking. And I was able to fit it in my budget after I reduced expenses for ERP. So we actually think this clarity is going to help both internally and externally. And we're not asking people to make changes until their materials run out. So things like stationery, business cards, etc., we're not going to invest in the expense to change those things until the materials run out. So we think we've done it in a very efficient manner.
Thanks, Rose. Okay, with that, I'm going to kind of turn back to some of the top of the presentation topics. We have a few related to infectious disease, so I'd like to ask Dr. Washer to pop in.
Yep, I'm here. Thanks, Keith.
Thanks, Lorraine. A couple questions for you. One question was, when will we be able to stop wearing masks at the hospital?
Yeah, I think that's a really relevant question, as many of us have changed behaviors outside of our workplace. What I can tell you is that leaders from human resources, occupational health, infection prevention are developing policies and procedures to really guide those changes on masking policies. And conceptually, we'd really like to move to a program which is supported by science, where vaccinated employees would not be required to wear masks in non-clinical buildings or areas. All employees would be continue to have to wear those masks when caring for patients or in clinical areas, but really this requires robust data on our employee vaccination that's verifiable and potentially visible. And so there's work being done on this now to address how this might be implemented, taking into account many different factors. So I don't have an answer about when, but I think that's the general direction that I foresee.
Thanks. And a somewhat related question. One person writes, hospital-based education programs like the residency training programs depend on space for teaching and didactics. Do we have a sense of if/when Michigan Medicine will be able to enable greater than 10 people to gather in a room for clinical education?
Yeah, that's being considered kind of in partner or in a tandem with this idea that we would be able to have different masking requirements for vaccinated versus unvaccinated employees, students, and others. And so I see that kind of coming together with the whole package as we change our approach here.
And last question for you, Lorraine, but I'll also ask Dr. Miller to pop in if he's available to see if he wants to field this one. It's a question we've gotten, almost every town hall in the past, but I think it's worth, bringing out again. And that is, when will COVID vaccination be required, or will it be required for all Michigan Medicine employees? And if David's available, I don't know if he wants to field that question.
Yeah, I'm here, Keith. Thanks. Sure, I can start. So I will ask Lorraine to comment on the effectiveness of the vaccines after I make my comment. So at present, there are no specific plans for mandatory vaccination. There are lots of dialogues about this issue ongoing locally, regionally, nationally. Our goals have been to make the vaccine immediately and easily accessible in an equitable fashion, to share information about the benefits of the vaccine, and to support all of our colleagues across the organization in discussions about vaccination. I think we're clearly seeing data that strongly suggests both the safety and the effectiveness of the vaccine. And I think it's important that we share that information plainly and consistently across the organization as a way of supporting efforts for our team members, our patients, and our communities. And I'd ask Lorraine to share, what we know. And I know Sandro's on the call too, and Stan, if they want to add any additional details. This is a really important topic and one that we should spend a couple minutes reviewing.
Great. I'll start, but I would love it if Stan or Sandro want to add anything. So there's no doubt that vaccination will improve employee and patient safety. And it's really our duty as we put patient safety and employee safety first to get to a very high level of vaccination, both across our employee groups. We know that the vaccine is very effective, and it's effective. Dr. Miller showed you the number of patients who have required hospitalization because of COVID infection, who are completely vaccinated more than 2 weeks, after their final vaccine dose is incredibly low. And so it's a very, very effective vaccine, probably more effective than any of us could have actually imagined it would be. And so very effective. And really the amounts of adverse effects that we see from these vaccines, the majority of those are very short-lived, certainly less than the side effects or the effects that we would see with COVID infection. We're learning, in each time that there's a signal that there might be a more serious side effect that's being investigated, across from experts across the country to sort of look at how likely these adverse effects might be occurring, whether they're associated with the vaccine or not. But even, when these signals occur, the evaluation is really bearing out that these are very infrequent, potential more serious adverse events, and that it's a really, really safe vaccine that is very effective. And we all need to seriously consider getting these vaccines for ourselves and our families if we haven't already.
Thanks, Lorraine. Maybe in the interest of time, if Sandro and Stan Kent have additional comments, that we can do that in the written FAQ. So David, Lorraine, thank you both for popping in for that question. Let me move to Dr. Zink. Brian, if you're available, got a couple questions for you, faculty related.
Yes, here, Keith, go ahead.
Yep. First, do you have any info on when university affiliated travel restriction will be lifted? Month, date? This person writes, my MishMed faculty were hoping to begin traveling again this fall. And I actually think, and we did have another question that maybe Dee can field as well when we bring her back. I think a similar question from a staff member asking about business-related travel.
Yeah, I would hope that we have firm information by the end of June for this. We're awaiting guidance from the university, which does have the overall say in our travel and hosting policies. So we are working on it, talking with the university, and it will open up. I feel confident by the fall. It's just a matter to what degree. So we hope to have a communication out by the end of this month. I think at the latest it would be early July. So hang in there, and we will hope to be able to convey that to you in a few weeks at the most.
Thanks, Brian. And I'll just build on that a little bit. I'm aware, our goal for FY22 budget is to bring back about 50% of our pre-COVID, business travel and professional development expense. And assuming that the university does green light, travel again for business reasons, that would be the general sort of budgetary goal. Brian, the second question I have that's faculty related. This is a staff member actually writing, I get 360 feedback from faculty. Has there been thought to enabling faculty to get 360 feedback from the staff during their evaluation process?
Yes, and it's done on a level that's more limited than we would like right now. But we are actually have had discussions just in the last month on this with our faculty development and faculty affairs teams about how we could do 360s more routinely for our faculty, especially our faculty who are in leadership positions in the clinical setting or research setting, education setting. And so it's something we're really interested in. I firmly believe the value of having an anonymous 360 is really critical to people's career development. So it's just a matter of being able to scale it at that level, and to have a tool that's simple for people to fill out too. That's something that is not 40 questions long and takes you an hour to complete, but something that is much more manageable. So we're actually exploring that right now, and we hope to be able to use it more widely with our faculty and our physicians in the future. So thanks for that question.
Thank you, Brian. I think that covers the faculty related questions for the moment anyway. Hey, Nancy May, can I bring you in for a pretty tough question that we definitely need to talk through?
I'm here.
All right, thanks, Nancy. And this is a hard question, so I also respect if you want to think further, but there is a real question at the end of this statement and a good and important question. This individual writes that he or she has been receiving multiple complaints about our emergency department for a year. This is a gateway to our system. We should take, all caps, every care to take care of them in a timely and safe manner. And this individual notes that he or she was aware of several patients die at home first couple months during the COVID last year, presumably because they were avoiding the ED, I'm not sure. Then this person writes, now we hear from others that they would never come back. And then the question, and this is a really good and important question, what can we, all caps, WE, do as RNs to facilitate better care in this regard? And that's obviously a complicated and a huge and a really important question, but if you have a few initial thoughts, maybe we can follow up with more.
So sure. First of all, I have the utmost respect for our emergency room nurses. It has been an extremely challenging time for many healthcare providers, but our emergency room is really the front door for many people who need care in an urgent way. And as we all know, during the pandemic, the height of it, there was many patients that we tried to avoid come into the healthcare to help decrease spread of disease. So other alternatives were established in our ambulatory care areas to divert those patients to come into the ED and do telephonic outreach in our ambulatory care areas. Drive-through clinics were stood up to help decompress the ED. But we continue, now that we're coming out of the pandemic, this third surge, have had extremely high volumes of patients that have delayed care and have come in through the ED. So we have had some challenges in spite of trying to get ahead of staffing in the emergency department by bringing nurses on and getting them oriented. We've had many people that have been out either on FMLA or other reasons that they're no longer working here. Some have transferred into other departments. And so we continue to try to, once again, increase our staffing. We look at it, to be honest with you, on a daily basis. There's a lot of discussion going on currently on how we can continue to support the emergency department so they have adequate staffing. They have been, I hate to say, plagued with this volume of patients that we've had to increase surge space within the emergency department and nearby areas, which causes us to pull nurses from our float teams and others to help support that care. But it is something that we continue every day to look at and find ways that we can support the emergency room nurses, as well as the entire organization as we continue to work through the pandemic. I can tell you that Dr. Miller has been down in the emergency room several times during the last several months that he's been in his role. We continue to work with the leadership teams in the emergency room, as well as Kathy Kendrick, our interim CNO, and Julie Grenwald, who is our ACNO in the emergency room, and work closely with John, our nurse manager. And so, David, I'm not certain if you have anything else that you would like to add, but for sure, there are ways that we can continue to strive to provide excellent care, and we continue to look at other ways in which we can support that department.
Yeah, thank you, Nancy, and Keith, thanks. I agree. This is an incredibly important question and one we have to continue to address together as an organization. And Nancy mentioned a number of issues, and I think we have to think about this across the entire spectrum of care. We have to ask questions about what are the reasons why patients are presenting to our emergency department. Many of them are true emergencies where that urgent care is needed. But I think we have to think about mechanisms by which we continue to improve and advance access to our ambulatory clinics, so that when patients call, the symptom management occurs, the access to our ambulatory clinics occurs, and we can avoid visits to the emergency department. And in fact, there was a terrific presentation last night from Julie Ishak regarding our kind of nursing call triage line in the medical group through our developing contact centers. And already exceeding a goal of fewer than I think the goal was fewer than 11% of patients calling ended up being referred to the emergency department. And there was dialogue with Bob Newmar from the emergency department about continuing to work on that. So that's one mechanism. I think that we also have to look at, once patients arrive in our emergency department, how do we allow them to receive the care they need in the right setting in an optimal and an efficient fashion. And so we've supported care management presence in the emergency department to help us identify those patients who might be able to be admitted to St. Joe's or Chelsea as an alternative to the main hospital, as well as patients who might be able to take advantage of expedited ambulatory visits within 24 or 48 hours in a number of different areas. I think we have to refer back to Dr. Jenk's presentation, that there are patients who are progressing in symptoms at home who might be able to admitted to hospital home, or as we continue to work with payers and other partners, patients to be able to go from the emergency department to home, and then patients in the hospital to be able to be discharged earlier and safely to home, allowing that next bed to become available for patients in the emergency department. So there are multiple factors that are at play here, while all the while layering in safe staffing, a safe environment in our emergency department and across the hospital. This is one of our opportunities and challenges that I mentioned at the beginning of the town hall, but one that I know we'll continue to work on together moving forward.
Thank you both. I really appreciate those responses. Now, from my standpoint, our emergency department team members are absolute heroes, and I thank them every day for all the work they do. And I also just want to say I really appreciate the we in that question, right? These are complex challenges, and it's going to take a team to solve them. So thank you for that question. With that, actually, great segue. Let me just pull Grace Jenk, Dr. Jenk in for a couple follow-on questions related to hospital at home.
Hey, Keith.
Grace, thank you so much. Just a couple interesting questions following up on your presentation. One person writes, how far do the patient monitoring at home, house calls, and hospital care at home capabilities extend geographically? How far away from Ann Arbor does the radius for each of these services extend?
Great question. So for acute care, hospital care at home, we are looking to enroll patients in the Washtenaw-Belleville area. Really a 25-mile radius is typically what other health systems have used, because if in case somebody needs to go back to the hospital, you want to get them right back as soon as possible for escalation of care. For house calls, we also see patients within Washtenaw-Belleville area, but we can do virtual visits as well, and that can extend across the state. And then for patient monitoring at home, we can send these kits to any patient in the state of Michigan. So we have sent some kits all the way out to Traverse City for a bilateral lung transplant patient. So across the state, pretty exciting.
Awesome. Just a great fundamental program. So amazing. Actually, we have another question, Grace, related to research opportunities with respect to hospital home, but I think I'll ask that we respond in writing on that one. I want to squeeze with just 2 minutes left. Let me just ask Dee to come back in. I want to get a couple HR questions in before the top of the hour.
I'm back.
Dee, a couple different questions related to the merit program this year. One person just simply asks, what will our raises be this year? And somebody else asks, what's the cutoff hire date for eligibility for FY21 merit?
I believe that date is April the 1st, and we'll make sure we put it in. It is April the 1st. If you're hired after April the 1st, you will not need to complete our complete evaluation. You'll do the probationary one after 6 months. And with regards to our merit program, we will be waiting for approval in the next week or so. And then after we get approval, budget approval, then we can announce what the merit program will be. So look forward to that at the end of the month.
Super, thank you, Dee. And last question before we run out of time here. One person asks, will hospital HFS-CME workers who have worked through the pandemic but are slated to move to campus structure receive the recognition bonus as well?
Those employees at the time of April 1st would needed to be an employee of Michigan Medicine as of April the 1st.
Okay.
So no.
Okay. With that, we're at the top of the hour. We have many questions related to your and Matt's Flexible First presentation, many of them quite technical, so they're actually probably better addressed in the written FAQ, and you both did such a nice job teeing up some of those FAQs already. That was great. And actually some of them were very much IT related, important questions that we'll need to follow up with and we'll need HITS input on. So I would ask everybody to look to the written FAQs for more information about the Flexible First. We're at the top of the hour. Thank you all again for your thoughtful and probing questions. Our next town hall will be Friday, July 9th at 2 p.m. Thank you all for all the hard work you do, and be well.